Welcome to this episode of Monday Morning Joe. I'm Dr. Chuck Vega from the University of California at Irvine. Monday Morning Joe is a quick-hitting coffee talk style 4-episode series where we discuss the latest and greatest regarding multi-cancer early detection tests, or MCEDs. So the goal of today's segment is to discuss why primary care clinicians should consider using MCED screening in clinical practice and provide some practical advice about how to do so. In the last episode, we reviewed the available clinical trial data for MCED tests. It was fantastic. Go check that out right away, but wait till you finish this episode first. Before we begin, I want to remind everyone to subscribe to the Exchange CME YouTube channel and turn on your notifications so that you don't miss new episodes in this series. And with that, let's begin. So if you're in primary care, you do a lot of cancer screening, correct? Right. And it's great. We've got 5 cancers that we routinely screen for in clinical practice, and that makes a difference. So we detect about 25% of all cancers via conventional screening. But even with those cancers, because we know that cancer screening rates for individuals are not near 100%, most folks aren't up to date with all of their cancer screening at a given time, and therefore about 18% of those screenable cancers, breast, prostate, colorectal, actually present with symptoms. So we're not detecting them through screening, but they're detecting usually at a more advanced stage when the patient's actually symptomatic. And then there's this huge group of cancers. We don't have any really effective screening tools for ovarian cancer, for pancreatic cancer, for esophageal cancer. Most types of cancer we are not screening for. And that's a real deficit because unfortunately that's where most of the mortality comes from, are those cancers we can't screen from. And so we've talked about the science of MCEDs, but how do you actually apply them? Who should be screened? So MCEDs, remember, are the means that we could detect many types of cancer. The Gallery test detects over 50 different types of cancer. So this is a game changer for screening, but who really should get this test? Well, it really should be limited to folks over 50 because age is such a important risk factor for cancer. And then the more risk factors that you have for cancer, you're a smoker, you have obesity, you have a family history, you have a history of childhood cancer. And unfortunately, I see patients who have not just one of those elements, but 5 or 6 different cancer risk factors. The more cancer risk factors you have, the more MCEDs really make a ton of sense, in my opinion. If you're 50 years old, and particularly if you have a risk factor, that's the person who needs it. It's not for folks who are less than 21 years of age. It's not for use in pregnancy. And folks who have an active cancer or they've had cancer diagnosed in the last 3 years, it won't be helpful for them either. And then just importantly to note, we don't stop our usual screening for breast, colorectal, prostate cancer, lung cancer, and with smoking history, those continue unabated regardless of using an MCED or not. So let's delve into the process for how you actually order an MCED. And it starts with assessing your patient, and it starts with talking to your patient. So you talk about their risk, you find out what their cancer risk is, and if you decide to move forward with getting an MCED, you are going to first educate the patient that this is a screening tool. It's not a diagnostic tool. So if you have a cancer signal detected and it says ovarian origin, you're going to do a workup for ovarian cancer. If it says liver origin, you're going to do a workup for liver cancer. So I think it's very important for patients to know that the blood test that they're going to get is not the be-all and end-all. If there is a cancer signal detected, you will be beholden to follow it up, and they have to be, obviously engaged with that journey. And there, it's pretty straightforward. You go to a portal, enter information. The kit will be mailed out to you. Patient can pick it up and then can take the blood test. There is a national lab that is helping to draw blood and ship blood to a national testing center. The sample is tested for currently available DNA methylation patterns, and the results usually return in that portal in 10 to 14 days, either cancer signal detected with its cancer site of origin or cancer signal not detected and can be shared with the patient. And so what are the advantages here? I think the huge advantage is detecting a lot of cancers heretofore we have not been able to screen for effectively. I think this is incredibly convenient for patients. They don't have to get approval for the mammogram. make an appointment, have that appointment canceled, miss the next appointment. This is something that's a blood test, which a lot of patients are used to getting, and something that's fairly convenient for them, that really offers no risk in terms of serious morbidity or mortality, unlike a traditional biopsy. And so those are great tools. On the downside, when we think about using MCEDs, the commercially available test gallery is expensive, and most insurances don't cover it. Although there is action to change that, and we see changes going on right now where there is increased third-party coverage for the gallery tests. So that's encouraging. We don't have a good schedule right now for how frequently you should get an MCED test. So that's something that I think will be elucidated with all the research going on in the next several years. But that's potentially an issue. And then there's an issue about overdiagnosis. Could we possibly be detecting cancers that really wouldn't make much of a difference in folks' lives? I would just counter that argument with, we really haven't been able to screen for cancers that are considered very dangerous and very deadly. Pancreatic cancer, ovarian cancer, esophageal cancer, upper GI cancers come to mind. And boy, it seems like if we could detect those cancers before they hit those later stages when we know there's a high risk of mortality, that would be absolutely outstanding. I discussed the fact that most cancers that are eventually diagnosed are not detected by screening, unfortunately. But the MCEDs could really change that by detecting over 50 different types of cancer, not only saying a cancer signal is detected, but giving the site of origin so we could target our screening. So with that, thank you very much for joining me today. As we discussed earlier, please check back for future episodes of the Exchange CME on the Exchange CME YouTube page. Remember that clinicians, pharmacists, and nurses can also go to exchangecme.com for free access to CME on a variety of different therapeutic areas. And I look forward to seeing you again in the next episode of Monday Morning Joe. I'll be discussing what to do as next steps after a person receives either a positive or a negative MCED result. I'll see you there.